Saddle up for a wild ride, VETgirl Pack. We're headed to the heart of Music City for VETgirl U this summer. So mark your calendar to join us for a rootin' tootin' good time, June 27th to 29th, 2025 at the Renaissance Nashville Hotel. We're bringing the heat with hot chicken, honky tonkin', and some seriously amazing CE. Hi, VETgirl here today, and super excited to speak with Dr. Reineke. We go way back. I'm embarrassed to say over 20 years ago at University of Pennsylvania, where we both trained in emergency and critical care. Erica, thank you so much for joining us today.
Thanks for having me. It's really nice to see you, Justine.
We were just chatting before the podcast. I can't believe how fast time flies. You're a professor of emergency and critical care now. I think we overlapped when you were an intern. I was a resident, but who knows? It was so long ago. But just so our audience knows a little bit more about you, do you mind giving us a little bit of background about who you are, where you trained, and what you do now?
Sure. Okay. My name is Erica Reineke. I'm a professor of emergency and critical care at Penn Vet. And as Justine just mentioned, I trained and did my internship and residency at the University of Pennsylvania. And I stayed on as faculty and started there in 2007. So it has been a long career, but I have stayed at Penn Vet.
Awesome. Well, I love what you're doing. I oftentimes will see your papers come out. And of course, I know you have a passion for toxicology and acute kidney injury, all things emergency, all things critical care. So, what I actually wanted to talk to you about today is a recent paper that you published. This was in the Journal of the American Veterinary Medical Association back in 2024. And it was entitled Clinical Course and Radiographic Resolution of Pneumonia in Dogs Treated with a Shorter versus Longer Course of Antimicrobials, a randomized double-masked placebo-controlled study. And before I begin, I just wanted to say huge kudos to you because nowadays in vet med, a lot of studies are retrospective, which are oftentimes weaker. So being able to see a double-masked placebo-controlled study is quite amazing. So first of all, why did you decide to do this study? Because our mentor, Dr. Leslie King, rest her soul, she had passed away several years ago, but she had taught us dogs with clinical pneumonia had to be on some type of broad spectrum antibiotic for 4 to 6 weeks. So tell me why you even did this study.
Yeah, you're right. So we were both taught to continue antibiotics for a long time. And actually, I was taught to continue them for 2 weeks past radiographic resolution of pneumonia. And I remember at the time when I was training, I was like curious of where those recommendations came from. And when you dive into them, you realize that there really is no evidence behind those recommendations. And it was mostly based on expert opinion. And I remember, I always tell the story. I remember I was treating a dog with pneumonia in the emergency service, and the dog was owned by a physician, a human physician. And I was explaining to her, hey, we're going to start your dog on antibiotics for the pneumonia, and we'll see him back in a couple weeks. And then we're going to continue the antibiotics until the pneumonia has resolved and 2 weeks beyond that. And she just gave me a kind of funny look. And I was like, what? She goes, well, we don't do that at all in people. And I said, yes, I realize that, but this is, what we do in veterinary medicine. And she's like, all right, I'll do what, you tell me to do, which was great, right? We love a client that is going to do what we tell them to do. But just over the years, it became more and more apparent that the way we were treating pneumonia, maybe it wasn't completely appropriate. So we wanted to investigate whether, a shorter course of treatment would be appropriate. I would say too that in 2017, I believe there were consensus recommendations that came out for treatment of dogs with antimicrobials. And in those consensus recommendations, there were recommendations for which type of empiric antimicrobial you should choose for a dog with pneumonia. But when it came down for recommendations of how long to treat, the consensus guidelines basically said, hey, we can't make recommendations because there's insufficient evidence for that. So that again was another just kind of something that put on my radar, like, hey, this really is something that we should look at more thoroughly. And there have been a couple studies prior to mine that have investigated this, but none in a randomized control way. So that was kind of the goal of our trial.
Like I mentioned before, huge kudos because again, most of these are retrospective. I published with Kelly Tart two retrospectives on aspiration pneumonia. And again, there's so many limitations of retrospective that a lot of veterinarians aren't aware of, right? Like, first of all, half the data is missing because if you don't enter it into the medical record, it's never in there. And so, again, just being able to see that it was a prospective study, that it was also double masked, that it was placebo controlled and randomized just reiterates the strength of the study. We won't go into statistics or anything like that, but again, this is a really strong study. And thank you for mentioning the ISCAD guidelines. So for those of you guys who don't know about ISCAD, my little plug for the International Society of Companion Animal Infectious Disease, or ISCAD. Again, they release consensus statements every few years. These are things you need to know about. And again, in 2017, when they discussed recommendations for empiric antimicrobial therapy, again, there was nothing for duration, so we didn't know. And Erica, I know I'm sharing way too much information, but I remember when I had a UTI for the first time, I went into the doctor and she's like, here's your 3 days of Tribrissin. I'm like, 3 days? Compared to human medicine, what we do in vet med was so different 10 years ago or 20 years ago. So again, really interesting you had that same experience for the treatment of pneumonia. Now, do you mind just discussing? I know 30 client-owned dogs that had radiographic evidence of pneumonia were included in the study, but do you mind just talking a little bit about the methods of how you went about doing this study?
Sure. Yeah. So in this study, we looked at dogs with uncomplicated pneumonia. So by that, we mean that these dogs were otherwise healthy and they were presenting either with aspiration pneumonia or what we would consider community-acquired pneumonia. And we really wanted to limit it to that patient population rather than patients with what we would consider complicated pneumonia. So those dogs were excluded. So dogs with complicated pneumonia would be dogs that had cancer or dogs that were immunocompromised or had conditions that may predispose to recurrent pneumonia. So we really wanted this, what we could get as a close to homogeneous population of dogs to investigate first. So that was our population. And so what we did is we invited the dogs to participate after they had been diagnosed with pneumonia and were started on an antibiotic. So generally, we recommend that they return to the hospital at a 2-week recheck for an assessment and to recheck radiographs, since that's kind of currently the standard of care, at least at our hospital. So at that 2-week recheck, if the owners were interested in participating in our study, we, at that point, if the dogs were clinically improving, so the owner said like, hey, my dog is feeling pretty good, he's eating well, and on recheck x-rays or radiographs, the pneumonia was improving. It did not have to be resolved. It just had to be improved. Then the dogs were invited to participate in the trial and were randomized to either discontinuing the antibiotics at that point and then starting a placebo medication that looked just like the medication that they were given, or they were randomized to continue their antibiotics per standard of care, that we would continue the antibiotics for an additional 2 weeks. And then we saw both groups of dogs back in at a 4-week recheck. Hopefully that's making sense.
Yeah, that's
Okay.
fantastic. Thank you so much. Again, because it was placebo controlled, really important for the medication to look similar. So, because we always worry about the placebo effect, even in veterinary medicine. All right. So great information. And I understand there were some dogs that were excluded from the study, including dogs that had diseases that could predispose them to recurrent pneumonia. So like our smushed face brachycephalic BOAS dogs or laryngeal paralysis dogs, dogs with megaesophagus, or those that were on immunosuppressive medications or had a stent. So it does sound like the patient population was a relatively healthy, quote unquote, population of dogs that got that. Is that correct?
Yes, I would agree. We were really trying to focus on these really otherwise healthy dogs that just had pneumonia to investigate. We just didn't want any other confounding factors that could, influence how they responded to their treatment or potentially lead to recurrent episodes of pneumonia.
Okay, great. And since we're talking about exclusion criteria, for your inclusion criteria, it was dogs that had physical exam findings consistent with pneumonia. So things like fever, abnormal lung sounds, coughing, tachypnea. Did dogs require radiographs? Did they have to be 3-view? Did they have to have an endotracheal lavage and positive culture? Or what were your other inclusion criteria for the diagnosis of pneumonia?
Good question. So, all of the dogs did have 3-view thoracic radiographs because they ended up having a radiographic scoring done by a single radiologist so that we could compare their radiographic changes over time from their first radiographs when they were diagnosed with pneumonia to their 2-week recheck to their 4-week recheck to assess for improvement or worsening of the pneumonia. But in regard to other inclusion criteria, we didn't require that they have an endotracheal wash to confirm that they, had quote unquote pneumonia. That would have been ideal. We didn't do that because I guess standard of care anymore, most clinicians, especially at our institution, if it's a first time pneumonia patient, it's actually pretty uncommon for us to do an endotracheal wash and culture it if the dog is otherwise systemically doing well. And generally what we do is start empiric antibiotic treatment at that point. So because that's our standard of care at our hospital, we didn't require an endotracheal wash or like PCR testing. And in fact, actually, very few of the dogs ended up having that. I think there was one dog that had an endotracheal wash and one dog that had PCR testing, but don't quote me on that. But very, very few dogs actually had confirmation of their pneumonia.
And I'm glad you brought that up because, the purest ivory tower way oftentimes is to do the endotracheal lavage or to get a culture. But in real life medicine, which we try to preach at VETgirl, realistically, I know at least for me, if it was a dog that had a pulse ox greater than 92%, still had clinical signs consistent with pneumonia, had radiographs consistent with pneumonia, I was like, okay, we'll treat you outpatient if the dog is still doing well with that presumptive 2 to 4 weeks of antimicrobial therapy. And I should also reiterate, I was trained the same way, 2 weeks past resolution of radiographic resolve of disease. All right. And for those of you guys who have JAVMA access, I would recommend pulling the study because they have a great flow chart of what dogs were included and what dogs were excluded in a flow chart. And it's crazy that you guys had 523 dogs diagnosed with pneumonia, ended up eliminating 90% almost, like 439 dogs were excluded because they were brachycephalic or immunocompromised or had other diseases. So of a huge amount of dogs, over 500, 84 were eligible for the study, and only 35 dogs were screened for enrollment in the study. And you ended up having 30 dogs, of which, again, they were split evenly into 15 dogs in each group. So again, great, great information when you actually pull the paper.
I was just going to say, like in hindsight, we wished our inclusion criteria was a little bit more broad, right? That we included some of those complicated dogs because had we had a broader inclusion criteria, our study would have had many, many more dogs. So, yeah, it was to me that was actually somewhat shocking when we saw the numbers of how many we excluded and also how many declined the study. I think we had 49 dogs, almost 50 dog owners that declined participation in the study over the study period, which was also shocking to me because we thought for sure every client would agree to this because we were paying for everything. We were paying for the rechecks and we were paying for the antibiotics. But, today it's a busy world. People are like, can't be bothered to come back. And I think actually a lot of owners don't come back for those follow-up imaging. So I think that was really interesting as well.
You bring up so many great points. One of them being, as we were talking about, both of us are so ER or ES, emergency services oriented. The hard thing is when we do outpatient therapy, one of the reasons why we often lean towards 4 weeks of antimicrobials is because we didn't know if they were ever going to go back to a vet, right? We didn't know if they were going to recheck in 2 weeks. We didn't know if they were going to go back to the RDVM. We're just like, good luck, right? Which is very real life. So it
Yeah.
is really interesting. You can do a similar study in loosening up the inclusion criteria and have that be a resident study in a couple of years, right?
Yes,
Because
yes.
because it's a more complicated, it could potentially be a more complicated study that looks at a different target population.
Yeah,
Uh,
we did have that one dog that was a protocol deviation. Did end up including a dog with a pyothoracx. I think we were trying to look back. Why did we include him? And I think we were like desperate to just finish the study. It was a bit of an oversight, but that dog was actually randomized to the shorter course group, which is interesting. And that dog did great, which also argues that, yeah, someone does need to look at that complicated pneumonia group because likely we know we're treating them too long as well, that even though they have immunosuppression or things that may predispose to recurrent pneumonia, they don't need 4 weeks of antibiotics either. In fact, you might argue that it's even worse in that population if they're more predisposed to recurrent infections to keep them on a longer course of antibiotic, like increasing their risk for developing resistance, right? And disrupting their gut microbiome. They're already expensive, these patients. So we're also increasing the client cost by keeping those patients on antibiotics longer. So yeah, that's ripe for study would be that population of patients.
part two. I love it.
Or two.
All
Okay.
right. Well, I promised we weren't going to talk about any statistics, but talk to me about the results. What did you guys end up finding?
Okay. So first, I do want to say, you've probably already figured it out that we had so many exclusions and we only ended up with a small group of dogs. So 15 in the short group and then 15 in the longer group. We ideally were aiming for 70 dogs. So we just didn't hit it. And so unfortunately, despite being this randomized double mass trial, it was underpowered to really assess for significant differences in relapse of pneumonia between groups. So I will just say that at the outset. But basically, what we found was that both groups of dogs followed a similar clinical and radiographic course, meaning that in neither group of dogs did we see relapse of pneumonia, which is great, either radiographic or clinically. I think maybe the most interesting study finding, though, that I think is like a take home for the everyday practitioner is that we should not rely on our radiographs so much to determine our antibiotic usage because there were a large proportion of dogs at the 2 week recheck that continued to have radiographic signs of pneumonia. But clinically, they were doing great in both groups of dogs. And even at the final check, that 4 week check, there were still a few dogs. Most of them had radiographic resolution at that point, but there were still a few dogs, maybe five. I'm trying to remember my study. But there were a few dogs that still had some mild radiographic changes. So we really shouldn't probably be rechecking them at that 2 weeks for radiographic resolution of pneumonia. It's probably more important to find out clinically how they're doing. And if clinically the dogs are doing fabulously, there's not really good reason, at least based on my study results, to recommend continuing the antibiotics for longer. And so I think that's really, really important. That's going to save the owner money. It's going to allow veterinarians to utilize their resources more effectively, right? Not having to sedate a dog for repeat imaging if otherwise they're doing really, really well. And that's mirroring what is already known in people. So they've known this for a while in people that, radiographic resolution is going to take longer than clinical resolution, which is probably why that doctor, when I mentioned that we would recheck radiographs and continue antibiotics, she looked at me kind of funny, right? Because they've known this for quite some time in people that the radiographic signs are going to lag behind clinical resolution.
Awesome, awesome information. You know, it's crazy that 93.3% of the dogs had complete resolution of clinical signs by the first visit. And it sounds like
Yeah.
that visit was 12 plus or minus 2 days, so approximately 2 weeks. So that's
Yeah.
28 out of the 30 dogs. So really, really intriguing to know that. And I'm so glad you did it because now we finally have evidence-based medicine where we can say, yep, 2 weeks is sufficient. I remember, and this is probably going to blow the mind of a lot of people, but I remember in third year at Cornell, we had a really well-known famous internist who was giving us a lecture and jumped on this little soapbox and was like, hey, so much in vet med is made up. It's like hot packet for 3 to 5 days, or, the limping will go away in 5 to 7 days. A lot of these numbers are made up. So it's so great to see that we finally have evidence-based medicine on that. So knowing that 18 of 30 dogs are 60%, and 25 of 30 dogs, or 83%, experienced complete resolution of radiographic lesions at the first and second study visits. What's our takeaway? What's our takeaway? Do we even offer the pet owner to recheck chest radiographs at 2 weeks, 4 weeks, or what should we be doing?
Yeah, that's a good question. Personally, based on my study results, if I just look at them as well as some supporting evidence from another study that looked at thoracic radiographs and ultrasound findings, they actually had similar results to my study in that those changes were still present despite clinical improvement. And in that other study I mentioned, they looked at C-reactive protein as well, and the C-reactive protein was normal. So I think based on the results of these two studies, I don't necessarily feel like thoracic radiographs are necessary. If clinically the dog is doing well, do I think they should come back in for a recheck? Absolutely. I think that they should come in to see the veterinarian so that you can have a conversation about how the dog is doing. So that the owner can definitively say, yes, I think my dog is improving, and you can do your exam on the dog. I do think that would be ideal, but I don't think we need to rely so heavily on radiographs at that visit. The one caveat to that being would be if the owner comes in and says, he was doing better, but now he's not, or his coughing hasn't gone away. He still coughs a lot. Like one cough every now and then probably is no big deal. But if the dog is still significantly coughing or they're still seeing signs, well, then of course, I would certainly recommend recheck imaging in a situation like that. So there are some caveats to that recommendation.
Awesome. If for the longtime listeners to VETgirl podcasts, we always say towards the end what the limitations of the study are and what we should take away from this VETgirl podcast. And, while the strength of the study was extremely strong because it was randomized, it was double masked and placebo controlled, one of the limitations is the small numbers, right? There were 15 in each group. And in human studies, these human studies are 1,000 people enrolled, and we just don't always have that option, especially if people decline the study, which is insane to me, right? They get free follow-up care, which to me is crazy. In terms of the limitation of the smaller numbers and potentially not having bacterial confirmation with endotracheal lavage or, doing antimicrobial susceptibility, there's still some key takeaways from the study. But I should reiterate, remember, this is uncomplicated pneumonia, right? To confirm, were all these dogs outpatient or were they hospitalized? And is there anything you would have done differently, or what takeaway do you want our VETgirl listeners to take away from this paper?
So, in regards to the first part of your question, where all the patients outpatients, by the time we saw them for that 2 week recheck, everybody was home. So, at that point, they were outpatients. But we didn't report this in our paper, but the vast majority of these patients had been admitted to the hospital for some form of treatment, either a day or two of some fluids. Some of them were oxygen dependent in our ICU for several days. So, we didn't do any illness severity scoring on them to kind of be able to tell you how affected they were, at least at their initial diagnosis. But I would say all of them were inpatients at some point. But again, by the time we saw them, they had gone home and then were coming back for their recheck evaluation. So I'll say that. And I think your second question was Remind me.
Yeah, anything you would have done different for the
Differently.
future study for the resident in a couple of years when they look at a more complicated group of dogs with pneumonia? Is there anything you would have done differently, knowing the few limitations of the study, like sample size, bacterial culture, things like that?
Yeah, I think that, sure, in an ideal world, I agree with you that if we had bacterial culture or PCR testing on every patient to ensure that the antimicrobial was necessary in the first place and correct, that would have been ideal, wouldn't it? But again, that doesn't necessarily reflect like what is happening in clinical practice. And so ultimately, the goal of our study was not to investigate whether the empiric antibiotic choice was correct. It was more to investigate whether a shorter course versus the longer course were appropriate. So back to maybe what we talked about initially, there were 5 dogs that were excluded because when we saw them, they either were misdiagnosed with pneumonia. I think one was didn't actually have pneumonia on radiographs. There were a couple dogs, I believe, that were not clinically improving and their radiographic changes were not improving. So those 2 dogs were excluded. And ultimately, those could have been examples of empiric antibiotic failure. One of which I remember one dog actually had an endotracheal wash done and that we cultured Bordetella and had an antimicrobial change and then was not in the study. And then the second dog declined any additional testing and then went off and never came back to the hospital. So we don't really know what happened in that dog that we ended up excluding. But we wanted to make sure that those dogs that weren't getting better were getting appropriate care. So again, that kind of gets to the point of our study wasn't to assess for did they need antibiotics or not, or were the antibiotics appropriate. It was more to assess for the duration of time. And so that's why we did have those exclusions of those 2 dogs.
Love
Yeah.
it. It's such a great study. I mean, honestly, you should be so proud of yourself and your team for doing it
Yeah.
because again, prospective, double-blinded, just an amazing study. Great takeaways from this. And I did want to ask one question because I don't remember seeing in the paper. What was the most common antimicrobial that was used for the treatment of these dogs?
Yeah, so we stated that these cases followed ISCAD guidelines for empiric antibiotic choices. So the most common antibiotic that was chosen was amoxicillin and enrofloxacin. And the combination protocol was likely chosen because these dogs, again, didn't have endotracheal wash to confirm what bacteria or multiple bacteria were present. And we know that pneumonia often is multimicrobial. So it's, an appropriate combination to use.
Love it. Amazing study. Again, what do we take away from this VETgirl podcast? Look at the clinical signs, right? Make sure we're getting a good history. Clinical signs may be more useful when you're working with a pet owner to determine when we're going to continue or discontinue those antibiotics. And biggest takeaway for uncomplicated pneumonia, a 2-week course of antimicrobial therapy is sufficient, right? Again, it's not the 4 to 6 weeks with 2 weeks past resolution of clinical signs that all the penny CC people were trained for decades, right? So awesome study. Really appreciate you doing this study and for you being on today's Vet Girl podcast.
Well, thanks for having me. It was a lot of fun.